There was no difference in the rate of permanent stomas, and some suggestion that quality of life was better with a segmental colectomy. So, for patients with proximal disease, an option is segmental colectomy. There certainly would be area for discussion about doing a subtotal or abdominal colectomy. Patients with distal disease almost always need a total proctocolectomy. Rarely there's a patient who only has distal disease in which an abdominal perineal resection with a colostomy is appropriate. And in a controversial way would be to consider an ileoanal reservoir. And the final area that I'm going to talk about is anorectal Crohn's disease. You all know that this is a frequent and significant problem. About a quarter, in population-based studies, almost a quarter of patients with Crohn's disease develop perianal fistulas. The AGA has classified these into simple and complex. Basically, if they're low, have only one opening, and there are no associated problems, they're simple. If they're higher, are more complex in terms of involving the vagina or having an associated stricture or active rectal disease, they're considered complex. Surgeons use a different classification based on how much of the sphincter muscle is involved, so that these perianal or intersphincteric fistulas that involve very little of the internal of the total sphincter muscle, this is the internal sphincter and this is the external, we consider simple, and low if they involve a significant percentage of the external sphincter. That is considered a more difficult problem and labeled transsphincteric. Our goals in taking care of these patients in an ideal world is closure of the fistula. It certainly is to control sepsis and symptoms and to preserve continence. So for low fistulas or simple ones in which there's very little muscle involved, we can do a simple fistulotomy. So this would have been the external opening. Here's the anus, and there's just a small band of muscle, and that can reasonably safely be divided with little consequence. There are 21 studies that were reviewed doing fistulotomies for low fistulas in patients with Crohn's disease, and there is a significant healing rate. And this is 13 out of 21 had 80 to 100% healing rate, which is excellent and hard to achieve in patients with Crohn's disease. So it's a good operation from the point of view of healing. However, there was a wide range of incontinence reported, and I think it requires very careful judgment about how much muscle is actually involved if you're going to consider doing a fistulotomy. And in some series, a very high rate of these patients came to proctectomy or long-term diversion anyway. The more difficult problem is what to do with the complex fistulas, the patients who have multiple openings. This person has, to orient you, this is the anus. This is a more chronic fistula. There's pus draining here from an abscess cavity. This is an older series that looked at fairly standard treatment of treating people with drainage of the abscess or perianal sepsis and inserting a ceton. This was done before infliximab or other biologic therapies were available. And while that operation has been thought to be controlling clinical symptoms for the majority of people, the fistula healed or was quiescent in less than half. Almost half required another ceton, so clearly the perianal disease was progressing, and 15% required proctectomy. So there was a big room for improvement. So what are the options? You all are, I'm sure, very aware of the medical options. I'm just going to very quickly go through these. One that's been used and studied is metronidazole particularly, but antibiotics in general. There are no controlled trials showing that antibiotics are effective for fistulas. There are some uncontrolled trials. This is one looking at the use of metronidazole. 21 patients, 18 were maintained long-term on metronidazole. There was decreased pain and tenderness in all, and in this series, about half had complete healing. Another follow-up study looked at 25% of patients. When the dose of metronidazole was decreased, all the patients got worse, so they clearly had to be maintained. If it was restarted, not all improved, but a substantial percentage did. 16 of those patients received the drug for over a year, and half of them remained healed. The problem is another half developed paresthesia. So there's clearly a downside to long-term use of metronidazole, as you all know. Because of those side effects, Cipro is often used. However, there's very limited to no data about the use of Cipro and its success rate in treating perianal fistulas. Azathioprine has also been looked at. This is a meta-analysis that's now fairly old, but looked at fistula closure, which was usually reported as a secondary outcome in these studies. And there was certainly patients with given azathioprine did better than patients on placebo, and half of them had healed. They took about 3 months to close, maybe a little bit longer, and again there were significant adverse events associated with the use of azathioprine in this subset of patients. The study, which sort of changed the face of treatment of anorectal disease or fistulous disease in perianal Crohn's, was this study, which I'm sure you're all familiar with. In that group, 68% of patients received a 50% reduction in draining fistulas, and 50% or 55% demonstrated closure. This is really the number we're interested in. I think patients they're happy to have somewhat decreased drainage, but what they want is to be done with it. The mean duration of closure in that study, and those patients were just given 3 doses, was only 3 months, and 11% of them developed a perianal abscess. The Accent 2 trial also looked at, and this is designed so that the patients who responded initially to infliximab were then randomized to either get ongoing infliximab or placebo. And you can see that there was a significant rate, a better response, either just in fistula response, and again this is the standard of decreased drainage, and in complete response there was an improvement in the patients who had infliximab. So the question is, what's happening in those patients, and is it just that the drainage stops, or are they really healing? And there are now multiple studies published using MRIs and ultrasounds that show that in most patients there is a persistent tract underneath the skin, that they may not be draining and may not be symptomatic, but that tract persists, which fits with the fact that most of these treatments have required ongoing maintenance therapy in order to keep people asymptomatic, rather than achieving a status of being healed and being able to come off the medication. So maintenance therapy is often necessary. There are problems with this that you all are more aware of than I am, that antibodies develop, that immunosuppressive therapy in addition to the infliximab seems to reduce that rate of antibody formation, but the therapy is expensive. And I don't know about you, but I certainly have encountered patients who come to me and say, I can't take that drug because I can't afford it. So they need a surgical option. Another option has been looked at is cyclosporin. There are no controlled trials that show that cyclosporin is effective for perianal disease. There are 10 uncontrolled studies with a significant response rate. This is typically IV cyclosporin that was converted to oral. However, there's a very high relapse rate when the oral medications are stopped. Tacrolimus has also been used in one randomized controlled trial at the Mayo Clinic in 46 patients with fistulas, 43 of them, so the majority were perianal. Again, this is looking at that standard of a closure of 50%, which I think is quite hard to measure. And they did find, by that standard, a significant response rate to the tacrolimus. However, when you looked at closure, there really was no significant difference between the placebo and the drug.